Hello.
Hello, it's good to see you.
Likewise.
Okay, welcome everybody. We love to know where people are joining us from. So if you would let us know where you're joining us from in the chat, then Bart and I can have a look and enjoy seeing who we've got with us today. It's a little bit strange sometimes when we're just talking to a screen and we can't see who's watching. But just make sure the chat is enabled. So chat. Yeah, there we go. And everyone, there we go. Chat's enabled. Sorry, it wasn't before. So I'm just going to pop in there where I'm from.
I should do that myself. Yeah.
Natalie from Australia, welcome. Welcome, welcome. Marjolaine from the Netherlands, welcome. Brendan from Alberta in Canada. Oh, so good to have. Look at this international community.
It
Love it.
is.
Love it.
USA. Oh, you guys, you're early.
Oh yeah, yeah, a little bit early. Oh, who got Irie? Oh, Irie, hi from Switzerland. Hi, it's great to have you. Stuart from the UK, Anna from Hartford in the UK, Ariane from the Netherlands, Emma from Ayrshire in Scotland, and Katrina from Wiltshire in England. That's fantastic. Oh, playing for the team here at PTC in Harrogate, Marie. Oh, you're not far from me. So I'm just north of York. So you're sort of one of my local towns. Lovely to have you. Thanks everybody for joining. Right, we're not going to hang around because we're very likely to run out of time on this session. So I've got an introduction and I'm just going to run through that and then we'll get kicked off. So good afternoon, good morning, or good evening, wherever you are in the world, and a very warm welcome to this introduction to treating functional neurological disorder, or FND, how we'll refer to it through the session. My name is Joanna, and I am co-founder of Le Pub Scientifique, which is an online platform for clinicians to learn about treating people with all types of pain. And I'd like to welcome today pain specialist physiotherapist and my very good friend, Bart van Buchem. Bart
Hello.
is also co-founder of Le Pub Scientifique and has a special interest in treating FND. So, hi, Bart. Great to see you.
Hello. Yes.
This is
Good to
our
see
first
you
time
again.
doing this live together, so you just have to forgive if we're a little bit disjointed. We're just sort of getting used to each other.
Yeah, we've done something similar, so I think we'll be fine.
We'll be
Yeah.
fine. So just before we start, I'll run through what you can expect. Bart and I will be talking for about 20 minutes. If you do have any questions, please put them in the Q&A or the chat, and we will monitor those streams throughout the session, and we'll get to as many of the questions as we can. And we've left a little bit of time at the end as well to come back to questions. Today, we're given an introduction to FND. So, Bart, could you just talk us through what you're going to cover in the next half an hour?
So yeah, so we have basically created a whole course around F&D. So we can only touch on some of the introductory stuff, which is including what have changed over the last decade, because there's a massive shift in how F&D is being diagnosed since about 10 years now, and it's only getting into the implemented in the clinics as we speak. We're going to briefly touch on how the diagnosis is made by the neurologist and how this is assessed, and some going to show you a positive sign, and also got a video with me. I can show you more about how this looks like in the clinic, and I will touch on the concepts and the understanding of a symptom-led treatment approach. So I think this will very much for the interest of speech therapists, OTs, physiotherapists, manual therapists. I think will be a big learning curve, and it will be very helpful for you to gain some clinical confidence in treating FND. So I'm glad everyone's here.
Exciting. Oh, I can't wait to hear. Okay, so let's kick off. Could you give us a quick overview, Bart, of what FND is and why it matters to physios and other healthcare providers in daily practice?
Yes, that I can try to summarize it. Which basically it says it's a functional neurological disorder. But basically, we're talking about neurological symptoms like loss or gain of sensitivity. It will be loss or gain of motor control. You can see as such people having difficulties in walking, like gait disorders, difficulties in speech, if the inability to speech. For other people, is loss or gain of the sensitivity, where especially when it comes down to the the loss, it's very likely to be a functional loss of view, a functional sensory symptom, which is happening quite often in neurology. So people who will be referred to a neurologist, there is about, depending on where it is, so people will have a referral for neurological symptoms, but they will, in about 5 to 30 to 35%, will end up with this diagnosis like a functional neurological disorder. The difference is just very much depending on where this clinic is, right? If you are in a specialized movement disorder clinic, when people are diagnosed for or specifically referred for Parkinson's disease, you can see a higher, much higher rate of functional disorders than you can see in a average, let's say, a general clinic for neurology, which is interesting. And I think in my clinic, and I think my clinic is not really a normal clinic anymore, as we've seen a lot of people with FND and referrals. But on an average, I would say about like 10 to 15% of your population today would probably consist some degree of functional neurological disorders, will have features of it, and not necessarily the diagnosis, but you will recognize some of the features, especially today when I show you an example, you say, oh, actually, this is very much like a functional neurological disorder, which doesn't mean you have to go through the whole process, but I think it's very good for us for our understanding, and we have to see the signs and the symptoms that fit this diagnosis. What is very important to me, this is a neurological disorder, as it used to be a psychiatric disorder. It's still in the psychiatric handbook, like the DSM-5. But what is most importantly, the criteria of that there should be, or there had to have to be, a psychological trigger, that one is not relevant anymore. So just for your just for your understanding, so a person can get this diagnosis without any psychiatric comorbidity or trigger, which used to be not, and before it was known as conversion disorder, but nowadays this term conversion disorder, also for the stigma problem, is being made redundant, and you can see the guidelines are going to consistently use the FND diagnosis instead of conversion disorder, which is a very old term, which basically introduced by Freud. And you just have to know your history. That's a long time ago, and we moved forward, and we think there are much better reasons, or there's much more proof that we can see there's a neurobiology that is changing and shifting in the brain, and therefore we can consider this as a brain function disorder, like any other neurological disorder.
That's fascinating. So
It
many.
is. It's very
Absolutely
fascinating, and just to
incredible.
have to stress that it's not, because there are many people with psychological issues in this group,
Yeah.
but it doesn't add up for, it's not necessarily for the diagnosis, and that's very important. Around 35% will not have any psychiatric label or
Wow.
whatsoever that's related to this diagnosis. 70 or 65% does have a relevant psychiatric diagnosis, which probably we have to take, well, we have to be aware of that.
Mm.
But there is this balance that has shifted from 100% psychiatric to a different level. And we also have found ways of treating this that is more in rehab type style of treatment, instead of going straight into the psychodynamics or
Yeah.
the psychotherapy approaches.
Fascinating. So we're going to come on to sort of some treatment stuff
Yep,
a bit later on in the
let's do it.
presentation.
Absolutely.
But that, yeah, absolutely incredible. change in the understanding around it recently, the last 10 years. Incredible. Okay, so we're just going to move on now to have a talk about assessment and diagnosis. Bart, what are the clinical signs of FND, and how are these positive signs assessed?
Yes, that's a great question. I think this, in the first place, this is a neurology field. So we in the ideal world, every FND hypothesis or differential diagnosis should be made by a neurologist. That's not always possible. That's absolutely true. But what we have to take in mind that there is actually, it's all about objectifying and watching the patient doing. So positive signs like distractibility, that's a very important feature. Distractibility will be a common positive sign because the symptoms will change, or in many ways will improve when distractibility is offered. So
Can you just explain a little bit about what distractibility
yes,
is like?
so it's basically shifting your attention. So this will be typically someone who's having trouble, for example, picking up a weight or a pen, not able to do it without having a tremor.
Okay.
But when you observing them and you can see them doing similar things and they are distracted from the task, they do much better. So that will be a sort of positive sign. There are other more sophisticated ways, and I'm going to show you a video here that would be helpful to get an understanding, because especially in tremors, you can see there you go. You can see in this video how it would look like. You can see this woman is she's having this tremor on their left leg, but when she is doing this, we'll call this entrainment. So we're going to add a movement. So you could say this is a combination of shifting your attention, but also another motor task. Now you can see what's happening when she is actually moving her right leg. You can see her tremor is instantly changing. And I will ask her how that feels. And when she stopped doing it, the it's actually the tremor comes back, right?
Yeah.
So you can see how this distractibility, but also this motor control has been largely able to change. And typically in a Parkinson's tremor, you won't see this type, and that's where the neurologist is very important, because this neurologist has to make the distinction between whether it's a Parkinson's disease or not. So, but from a clinical point of view, you could easily use this. So this is also like a starting point for treatment, because you might be able to use these type of distraction, if you like, or entrainment to using your therapeutic approach. And
Mhm.
that's pretty cool, to be honest.
That's pretty
And it's
cool.
indeed, and it's also like a positive movement experience for people. So they start creating sense of agency. So once they get basically able to regain some agency over their bodies or their movements,
Mm.
then that will be a massive learning curve for people. So
Yeah.
incredible we've seen incredible, well, improvements in patients in only minutes. But to be honest, most people, we have to work very hard. It takes quite a bit of time, but sometimes you can just change it instantly. And using entrainment or distraction or even other movement patterns, like people seems to dance very well and they're having massive troubles with just walking.
Mm.
And well, in our course, we will provide some of these examples where you can actually see what's happening um, when people are performing the specific task, that are creating like an autonomous movement where don't think about it and just go for it, and it's improved so much that people can see and feel it as well, and that's very
I
helpful.
love the fact that something that's obviously a very complicated disorder is like some of the actual practical things that you can do are simple. It is very much about trying to convert this knowledge and understanding into practical, simple, clinically applicable things that you can do with your patients.
Yes, and this is especially relevant for the motor type of functional disorders. So there's also the dissociative, with people passing out, or sort of they get like epilepsy type of attacks. These will be happening. I think it's less relevant for physios and let's say these allied health professionals, although you might see it, because these symptoms may come together, right? So people may have a tremor on the left end, but they also having these seizures. So and there are some great ways of managing that, but it probably also needs or requires a psychologist to be included in this in the approach,
Yeah.
which goes a little bit beyond, I would say, what a physiotherapist would normally do in this therapy.
Really, thank you, Bart. That's so interesting, so much in there. So just moving on to actually focusing on the patient here, how do you explain the diagnosis to patients in a way
Yes.
that
Yeah.
is trusting and builds trust with the patient?
Yeah, so first thing, don't call it psychosomatic, or it's all in the head, it's in the brain.
Mm.
People will definitely wouldn't be happy about it. There's a paper from John Stone who's calculated the number needed to offend, which is sounded a bit funny, but it's that serious. So
Yeah,
people would accept the the term if it's all in the head or it's in the mind, as or even when it's conversion, 1 in 2 will say, well, that's not my story,
yeah,
and they won't accept the diagnosis. If you say it's a functional neurological disorder, it's about 1 in 10, 1 in 9 would sort of um, um, won't accept the diagnosis. So that's a massive. So in the word, there's a lot, right? But also in the way it's been described as a brain function issue, also potentially triggered by psychological factors, but equally it could be a virus, could be a physical damage, if you like, that happened, or an injury that has caused them, that had or triggered it at least. The cause is not known, right? So we could be very clear. You don't have to tell people about how it's been, why this person um, does have what happens, or getting this troubles with or this diagnosis. But what we can say is that it's been triggered by multiple factors, and it doesn't necessarily have to be a psychological trigger. And it's a brain function issue. And sometimes, like metaphors, like software instead of the hardware is an issue, then people tend to accept that easily, or much easier when it's different. But I think this is also about in the whole treatment. It it requires some creativity. And from our background in also in pain education, you shouldn't have a one fits all solution type of education or explanation. It has to be fitting the story of the patient. So many people do have their own, they will have their own narrative around this. And I'm sometimes quite surprised of how much people actually have found their own story. And you can say, well, that's probably very relevant. But it's also for reaffirming and re-engaging or engaging people in the story, and so they can start working basically to retrain their movement and retrain their senses, and getting on board for the rehab. So actually, you can do something instead of just waiting until the stress moves away, which typically is not always helpful for this type of conditions.
Thank you. Really, really informative. Thank you. So just moving on now to have a look at some fundamentals around treatment. uh, where do you start with treatment when a new FND patient is referred to you?
Yeah, so again, it's going to be thinking about the movement, the tremor you've seen on the video. I think that will be, especially when you find something that is actually changing the pattern of the tremor, then that will be my starting point for both education, understanding, creating a sense of self. So it will be emotion regulation. If people getting stressed about this, have to help them to regulate these emotions or or feelings, and then using this entrainment to conditioning it. So that's what we're doing. We're going to give people an option to use it through the day, and that's what the first session will be about: is using this entrainment day by day by using it very implicitly, very much for themselves, but also using help of others. And we are going to create like an exercise program that will be allow people to basically to automating these techniques. And what we generally see when people do this very successfully, it really gets more automated. So they're not bothered about these symptoms as much. They can actually control them because they reduce when they start using these techniques. And in some people, in some patients, it's basically it just all disappears. They don't. It's a bit like having this aspirin in the back of your jacket, right? So in your pocket, and as long as you got it, it's all right. You don't mentioning anything. There's no trouble at all. But when you're missing, you don't have it. You don't have access to any of these. Um, then actually things are getting different, and people getting start to worry about it. So I think this is a lot about self-efficacy and self-control.
Yeah, I love that. So we're talking about entrainment, agency, and self-efficacy. Really important, each of those
Absolutely.
points.
These are the keystones for treatment.
Stones.
Maybe for every treatment, but more particularly, especially on the motor control, and compared to chronic pain, we tend to sort of move away from symptom control
Mm.
as it's not so successful. I would say in FND, it's worthwhile trying it, and you will find out that about 50 to 70% will have some benefit in doing this and learning about it.
Amazing. I mean, that sounds like a really positive statistic.
It's very, yeah, it's very, let's say worthwhile, but it's also it's like how you trained as a physio or a speech therapist. You will find instant results. So that's also for the therapist. It's good fun to work with.
100%. Yeah, that's definitely strikes me that you've got scope here to really see progress.
Absolutely, it's not easy, but you can learn this pretty easy. I would
Yeah.
say you can learn it. So
You're
that's
obviously
where
making this seem really easy, Bart.
yeah, and I'm
But you,
realizing that it's not always like that. So we will get to some questions right now, I guess, and I can see already something popping
yeah,
up that
lovely.
oh,
Thank
actually,
you.
this is probably one of the challenges you may see.
Okay, so we are going to start talking about challenges now. And so I think let's just we'll do our first question and then Marie will come to your question. So, but how do you approach patients who are skeptical or when progress plateaus?
Yeah, so one of the main things will be people have doubts about the diagnosis. This would be typically someone like with a tremor, thinking of this patient I've presented that people say, isn't it a Parkinson's disease, for example? And from my view, and I think this is what we've also have debated on with neurologists and psychologists, is that we probably have to go back to the drawing table and going back to the neurologist, basically to reaffirming the diagnosis. So not believing what's going on or the diagnosis is right, that's absolutely a killer for treatment. Um, it can happen. Sometimes it plateaus and some people don't get better. I guess that's how we sort of go from there. If people need if they're plateauing, or finding out that it's working in the clinic but not outside in their own context is not working, we'll probably have to think of how we can help people to implement it outside, be more aware and more mindful of the challenges they face. Um, and I guess that's something that's happening with every diagnosis, because this is not very different to any other neurological disorder, in my view, in how we manage it in terms of challenges.
Thank you. Okay, we're going to take a couple of questions here because I think they're appropriate in this section. So
Yeah.
Marie has asked, oh, hang on, it's all going down now. Hang on. Where are you, Marie? You've just got up the screen.
Yes, comments about the tics, I guess. Marie,
About
are tics
tics. Here we
common?
go. Are
Yeah.
tics common with these patients?
Um, I wouldn't say common, but they are there. They are definitely there. They would be called like functional tics or clone. Is it cloney? I'm sure. I'm waiting. I'm checking the word.
Sure.
Uh, well, these are these I think the tics is, I think, is a good word. Um, um, it's like a contraction. It could happen everywhere. For some
Yeah.
people, have it in tics in speech. Those are less common, I think. But when it comes down to the clonus, yeah, thank you, Mark. And so myoclonus is happening, but it's not super common. But indeed, again, this is very important to have a neurologist to differentiate between like a organic or a clonus that is has like a disease reason, neurological disease that it's related to dystonia, for example. Then this neurologist is vital again.
Thank
It's
you. And Brenda says, if it is not psychological, what is then the trigger?
That's a great question. But I think this is very dualistic as well, right? So we think if this could be someone who's, I think recently long COVID has been related to FND in a way, because the symptoms are so much overlapping, like post whiplash injuries having similar features. Is it psychological? Well, probably it does have a psychological, let's say, part of it, right? Going through a disease or having a virus or waking up after surgery and losing sense of your body, for example, that could be quite stressful. But there is also a physical domain, if you like. Again, this is very dualistic, but what's more important, that it's not solely psychologically. It doesn't have to be a mental or a psychological trigger only by someone saying you're stressed out. So many people would claim, well, there was nothing, right? I seem to be quite happy. And even before the days that they were psychologists or within the psychiatry, this was this idea of that there must be something in like traumatic happened in your childhood, and we now know that's not fair to trying to diagnose something like trauma or childhood abuse in people who do, so you would not have that, or even suggesting it, because if it's not there, there must be something else. And with the, let's say, the old conversion type of diagnosis, this was one of the aims, to finding the trauma that happened but you didn't know about. And you can see now psychiatry is moving away from that field. They left that. It's proven to be wrong, and people are not getting better. Not saying that some people do have it, right? That's, I think this is the whole variety of people and therapists have to sort of figure out what's relevant.
Yeah. Great, thank you. I think we've got time for one more question before we start to think about wrapping up. From Denise, how can we assess the difference between sensory loss in chronic polyneuropathies and that in FND?
Oh, great. Well, we should ask the neurologists, I guess. But one of the things is where EMG, for example, could have a place. So if there is I would say if there's a likelihood of this is a polyneuropathy, which might be functional, it's probably the EMG will be negative, right? And if there is another way of diagnosing polyneuropathies, then, and that's a hard one in particular, but if you want to diagnose it and being sure about it, this is an ongoing process of making sure the neurologist has done this EMG type. So this negative result would sort of imply there is a likelihood of a functional, but it also needs the feature of that it probably is typically when people have these sensory issues with hyper aesthesia, then they would have this on and off. So they have it on the one day and then not. So they're basically having not the consistency you would expect with a polyneuropathy. It will be more a bumpy road, and it will be quite consistent bumpy. And when you're testing it, you also see discrepancy. So people will have an ability to identify pinprick, and other sensory testing will be having a different type of responses to what you would expect with someone with a full-blown neuropathy. But again, I guess that's is definitely the area of a neurologist to be sure about this type of differentiation.
Thank you, Bart. We are going to have to wrap up now, and I can see there's other questions, but what I suggest that we do is that I've taken a note of those questions, and we'll be posting this up to our Le Pub Scientifique YouTube channel, and we'll answer the questions in the comments there. So that'll give some nice content for people watching it as well. So we haven't forgotten about you. I've made a note. We just want to wrap up now because we're conscious of time and people needing to get back to work and things. So today, Bart, you've given us a fantastic high-level introduction to treating FND.
I hope so. Yeah. Well, make sure that I'm not alone in this. So we got this amazing course we've created. We've running this course already for 4 years in the Netherlands, and we've been able to get, like, I would say, leading psychiatrists, leading neurologists, researchers in this course together, and I was so happy they wanted to work with us. So I think if you have a look at it, because it's going to be mind-blowing if it's the first introduction. If you have been working with FND for a bit, I think this could be reaffirming and also giving you some new ideas and moving forward from that. So just a little bit of a promo for what we've done, but we're just very excited about what we've created, and I think it will be widely. So we have had some great feedback so far, and we're constantly updating it. So even if you've been already watching it, in the next couple of months, every time a new paper comes out, I will add it to this course, so you'll be sort of part of this little community, and we're just excited
so
about it.
excited about it. And if you want to really get to grips with this often misunderstood condition, we have this brand new FND Masterclass, which is available as part of our Le Pub Premium membership, which it is actually amazing. Amazing value. It's like £150, and you would normally expect to pay double or treble that for this kind of course. And the people delivering the course, as always at Le Pub Scientifique, we get the best in the business to come and deliver our material. So we've got consultant neurologist, Professor John Stone, who Bart has mentioned through his session. We've got neurologist, Dr. Jeanette Gelouf, and psychiatrist Sonia Rutten, and neurological physiotherapist Glenn Nielsen, who was talking about the research. But the course is incredible. You've also got Bart van Buchem and Tim Beans giving you some clinical coaching in there about how to treat the condition, and also giving some specific case studies as great examples. So if you are interested in that, I have dropped the link in the chat. Click through, check it out. And Bart and I will be doing another one of these sessions in about a month's time. So it will be FND again, and we'll be choosing a topic and drilling down to some more detail that we didn't have time to cover today. So keep your eyes open, jump into our YouTube channel, watch the recording, like, subscribe and share, and we hope to see you again in about a month. Thank you so much, Bart. That was amazing. Thank you.
I liked it. Okay, thank you
A
guys.
lot of
Bye
fun.
bye.
We love doing them. Take care, everyone. Enjoy the rest of your day and have a great weekend. Cheers.